The aims behind the following lectures of surgical infections are to understand the factors that determine whether a wound will become infected and the indications for and choice of prophylactic antibiotics and the characteristics of the common surgical pathogens and their sensitivities and the spectrum of commonly used antibiotics in surgery and the principles of therapy. Among the aims also is to know the definitions of infection, particularly at surgical sites, and what basic precautions to take to avoid surgically relevant healthcare associated infections. Surgical infection. Microorganisms are normally prevented from causing infection in tissue by intact epithelial surfaces, skin, and mucous membranes. The strict definition of wound soft tissue infection is more than 10⁵ colony forming unit per gram of tissue. Microorganisms are normally prevented from causing infection in tissue by intact epithelial surfaces. These are broken down in trauma or surgery. When enteral feeding is suspended during the perioperative period, and particularly with underlying disease such as cancer, immunosuppression, shock, or sepsis, bacteria, particularly aerobic gram-negative bacilli, tend to colonize the normally sterile upper gastrointestinal tract. They may then translocate to the mesenteric nodes and cause the release of endotoxins from bacterial cell walls, which can lead to a harmful systemic inflammatory response. That is decisive period. There is a delay before host defenses can become mobilized after a breach in an epithelial surface, whether caused by trauma or surgery. The acute inflammatory, humoral, and cellular defenses take up to 4 hours to be mobilized. This is called the decisive period, and it is the time when the invading bacteria may become established in the tissue. It is therefore logical that prophylactic antibiotics should be given to cover this period to prevent an infection from developing. Surgical site infections are infections of the tissue, organs, or spaces exposed by surgeons during performance of an invasive procedure. Surgical site infections are classified into incisional and organ space infections, and the incisional is either superficial, limited to skin and subcutaneous tissue, or deep incisional. The development of surgical site infections is related to 3 factors. A. The degree of microbial contamination of the wound during surgery. B. The duration of the procedure. And C. Host factors such as diabetes, malnutrition, obesity, and immunosuppression. By definition, an incisional surgical site infection has occurred if a surgical wound drains purulent material, or if the surgeon judges it to be infected and opens it. Major and minor surgical site infections. A major surgical site infection is defined as a wound that either discharges significant quantities of pus or signs such as tachycardia, pyrexia, and a raised white cell count. That is to say, systemic inflammatory response syndrome. Minor wound infection may discharge pus. The wound may discharge pus or infected serous fluid, but should not be associated with excessive discomfort, no systemic signs, or delay in return home. Types of localized infection. Abscess. An abscess presents all the clinical features of acute inflammation, that is to say, redness, pain, and swelling and loss of function. They usually follow a puncture wound, surgery, but can be metastatic in all tissue following bacteremia. Pyogenic organisms that produce pus, predominantly Staphylococcus aureus, cause tissue necrosis and suppuration. An abscess is surrounded by an acute inflammatory response and a pyogenic membrane. If it is not drained or resorbed completely, a chronic abscess may result. An antibiome may form if it is partly sterilized with antibiotics. Treatment of an abscess. Wound abscesses may discharge spontaneously by tracking to a surface, but may need drainage through a surgical incision. Most abscesses relating to surgical wounds take 7 to 10 days to form after surgery. As many as 75% of surgical site infections present after the patient has left hospital. Abscess cavities need cleaning out after incision and drainage and are encouraged to heal by secondary intention. All loculi need to be opened and curated before resolution can occur. Persistent chronic abscesses may lead to sinus or fistula formation. Cellulitis is the non-suppurative invasive infection of tissue. There is poor localization in addition to the cardinal signs of inflammation. There is spreading of the infection. Spreading infection presenting in surgical practice is typically caused by organisms such as alpha hemolytic streptococci, staphylococci, and Clostridium perfringens. Tissue destruction, gangrene, and ulceration may follow, which are caused by release of proteases. Systemic signs are common: systemic inflammatory response syndrome, chills, fever, and rigors. These follow the release of organisms, exotoxins, and cytokines into the circulation. However, blood culture in cellulitis are often negative. Lymphangitis presents as painful red streaks in affected lymphatics. Cellulitis is usually located at the point of injury and subsequent tissue infection. Lymphangitis is often accompanied by painful lymph node groups in the related drainage area. Bacteremia and sepsis. Bacteremia is unusual following superficial surgical site infections, but common after anastomotic breakdown. It is usually transient and can follow procedures undertaken through infected tissue, particularly instrumentation in infected bile or urine, such as cystoscopy. Bacteremia is important when a prosthesis has been implanted, as infection of the prosthesis can occur. Sepsis may follow anastomotic breakdown. Aerobic gram-negative bacilli are mainly responsible, but Staphylococcus aureus and fungi may be involved, particularly after the use of broad-spectrum antibiotics.